But we are excited about this morning's and this afternoon's program. I know the MPF team has done an incredible job putting together an agenda for you on a really important topic. For us at MPAF, we envision nothing more than a healthcare system that's able to deliver care that really is centered around the person and the individual and their caregiver. And to do that, you need shared decision making, and you need goal concordant care planning, and you need quality measurement that matters to patients so that you can pay for value based on what really matters to patients. But at the end of the day, patients have a lived experience and social determinants of health that also determine their ability to move through even a person-centered healthcare system. And part of that really involves the ability to help navigate patients through their day-to-day lives. And so patient navigation becomes a really central component to that process of person-centered care. And we live and breathe that work every day at Patient Advocate Foundation because we have about 50 individuals who spend their lives helping patients overcome social determinants of health and their caregivers on a daily basis. And the reason that's relevant is because to do that work, and of course to do the work of helping a patient express what's important to them and listening to those preferences and shaping care around those preferences requires communication. And communication is ultimately built on trust. So there's different levels of trust. There's trust, and when you have trust, you're able to communicate and say things about yourself and share with people in ways that are really meaningful and that build a relationship that is actionable. When there's distrust, it's even harder to create that. It's almost impossible to create that level of engagement and communication that's really going to allow me to engage in my care team and my caregiver to do so that they can make sure that the care I'm receiving is what is based on what's important to me. And then there's something in between where there's not distrust or there's not trust. There's sort of indifference or uncertainty. So those are the types of issues that if you can't overcome them, you cannot build effective communication, and you can't talk about and express the things that are happening in your life, especially as it relates to social determinants of health, so you can get the care you need, whether it's from your care team or whether it's from a patient navigator who can help you navigate through those experiences of life.
A little over 20 years ago, my career in health advocacy actually began because of an issue of trust. And I'm not sure I particularly I framed it that way, but that's what propelled me into advocacy. 26 years ago, almost to the day, I was diagnosed with non-Hodgkin's lymphoma. And when I'd been sick for 7 months. A lot of people know my personal story. I'd been sick, I'd been complaining, I'd been going to my doctor. I knew something was not right. I was 35 years old. I should not have been so out of breath. I should not have had trouble walking a block. I should not have had things happen that were happening to me. But I was treated, everything that I had was pretty much dismissed. And the more that I talked about what was wrong with me, and the more I didn't fit the profile that that physician saw in a young, seemingly healthy woman, the more I was dismissed. And so the last time I saw my doctor, he was standing outside of my, I always say hotel room. I wasn't in exactly a hotel. My hospital room, and he looked at me, and he looked across the threshold, and he said, "But you seemed so healthy." And that's the last I ever saw him. And so, like many, many people in advocacy, I went into advocacy because I wanted to change the experience for people who went after me. And I wanted to change the experience so that people would be seen as whole people, that they would be listened to, that they would be trusted, that they would be respected, and that what they felt was wrong with them was going to be given the respect and the attention that was due. So my wish is that for everybody around this table that there is nothing about us without us, and that's one of the things that we are going to be talking about today. And I know I went completely off script, completely off my slides, and I'm very far behind. So I just wanted to quickly go through, a lot of this is, so we're going to look at what does the reciprocal trust mean in communications between people and healthcare providers? Why is it critical to have trust as a two-way street? with providers trusting their patients as well as patients trusting their providers. And one of the things that was very clear to me in a lot of meetings, there have been a lot of meetings recently about trust, is that most of the conversations have been about why patients should trust their providers and why, based on historical harms, based on community harms, we have to get over that to have patients trust their providers. What nobody talks about are things like why providers need to trust their patients and why the providers who are often and who are always, I shouldn't say often, always in the position of power need to make that leap first, because the person in power, she who is in power, should make the leap to create that trusting relationship. How is trustworthiness built? Because it's not just about trust, but it's about trustworthiness. And you'll hear a lot about that later on. Then the other thing that I thought was really important, there was an article that was written by Dhruv Kular in JAMA, which was a synthesis of a lot of work that had been done by the ABIM Foundation Forum. Daniel Wolfson's here, on trust, and there was a series of articles on trust. And one of the things that Dhruv said was, we just make this assumption that trust is good and mistrust is bad. But when is mistrust both wise and necessary? And I think we will hear some conversation about that throughout the day, because there are times when when trust is not universally good, that there are reasons to mistrust and to address those issues. So then the other thing that we're going to talk about is identity and how identity and bias affect trust in clinical encounters. What can patients, caregivers, and providers do to improve trust? And how can more trust in clinical healthcare encounters lead to better outcomes? And as Alan said, one of our primary goals is to really look at how we can close the gap and how that can close the gap and ensure that there's equitable health for all, not equal health for all, but equitable health for all. So trust in clinical encounters significantly undermines health disparities, and we want to address those. So one of the things that we did when we, before we did this policy consortium to really frame the day, was we sent out a series of questions to the community. And I'm just going to I'm going to give you very brief highlights. We will send these around to you, put them on the website. But it is, so we had four questions. The first one, what are the most important things healthcare providers can do to create a safe, trusting environment? Every single person put listen. Listen, 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 and listen without judgment. Use clear language without being condescending. I've heard physicians and other healthcare providers say, oh, the patient's not going to understand what I said. I know, as somebody who's had several life-threatening diseases, I am really motivated to understand what you say. But it's about jargon-free, whether it's jargon in terms of whether it's clinical jargon or whether it's, I used to run a magazine, it was magazine jargon. It doesn't matter. It's jargon-free. And always be truthful. People know when you're not telling them the truth. And it is really, really important to be truthful, because if you're not truthful, that can help really significantly impact a trustful relationship. What are the barriers to the creation of mutual two-way trust? Again, all of these themes kept on coming up. Race, ethnicity, socioeconomics, insurance status. We're going to hear a lot about that on the first panel, where we do kind of level setting. How do we look at identity and trust? The EMR and other tools that can mediate communication, both verbal and nonverbal. And we're going to hear from Lolita El-Qureshi about a project that she's done at the University of Chicago about how to give power in using the EMR back to patients. Does the provider believe the patient? We're going to hear from a number of providers today, a number of healthcare providers, about what it means to how they get to the point where they believe the patient and how they see the patient in front of them. A lot of things, and we talk about this a lot at National Patient Advocate Foundation and Patient Advocate Foundation, are how billing, financial concerns, and insurance status impact how we're treated. And we will also continue that conversation. We've had that conversation through most of our policy consortia, and we will always continue to have that conversation, because that's a kind of identity, what kind of insurance people have. And last policy consortium, one of our panelists talked about the difference between when she had private insurance and one on Medicaid. It was a panel that Carla Easter from NIH Time's up, moderated. And then finally, so voices from the community. How can patients give providers a reason to trust them and to develop this mutual trust? Be transparent, honest, and share information. We all know that. Exhibit compassion and understanding for the healthcare team. So we talk a lot about exhibiting compassion for the patients, but we also have to exhibit compassion for for the team that's taking care of us as well, and realize that if we want to be seen as more than our disease, they also need to be seen as more than just their jobs. Ask for help, ask for clarifying questions, and once again, listen, listen, listen. So my final slide, and I'm going to then turn it over to my colleague Kate Gallagher to talk about some of the work that we've done in surveying our patient population. We asked people if they had ever felt unfairly treated by their healthcare team because of their identity. And we asked them to choose all that apply. Age, young and old. I referenced that earlier. It doesn't matter if you're young. It doesn't matter if you're old. There is ageism in the system, no matter what side it's on. Weight. This was a question that one of my colleagues, Katie Donovan, wanted us to put in, and it's amazing. Almost everybody chose weight on this. Income or ability to pay, race or ethnicity, religion. We don't talk about that very often. We don't talk about how people are treated differently because of their religion, particularly if they're in a minority religion. Disease or condition, whether you have cancer, whether you have HIV, whether you have kidney disease, that can change how people are treated. Education level, we assume people can't understand things because of their education level. We make assumptions about people. And sex and gender. So with that, those are the questions that we asked to help frame the day. I'm so grateful for you all to be here. I'm so grateful for the speakers to have come and joined us from all over the country. And I'm going to turn it over to my colleague Kathleen Gallagher, who is our Senior Director of Health Outcomes Research, to talk to us about the trust research we just did with our PAF population. So thank you.